This is fantastic. What a great opportunity and an ingenious idea. Ingenious.
Thank you. And he didn't say the D word.
I know. I have one disappointment. I have one disappointment because if people say the D word, then they have to buy us a glass of wine. And Stan, you're a disappointment. You never said the D word.
I was told not to say the word, and I did my best to heed your advice. It was very easy.
Well done.
Excellent.
Sorry for Saying Sorry Media presents the Purr Podcast, the best podcast for feline medicine and surgery with tips, tricks, and updates for the entire veterinary healthcare team. If you're dying to know more about cats, keep on listening. Here are your hosts, Dr. Susan Little, famous cat vet and textbook author, and Dr. Yola Kerpenstein, talented surgeon and social media geek.
Hello, this is Dr. Yola Kerpenstein
and it's Dr. Susan Little.
Yeah, this is part 2 of this amazing podcast that we have with Dr. Stan Marks. And I'm so excited that we're here again with him. 2 weeks ago, he did this awesome talk, and now he's back with us. So,
yay!
Hey, Stan, how are you?
Hi, guys.
Thanks for being here, Stan.
You look amazing, and in fact, Yola, you look like you're wearing the same suit that I saw last time 2 weeks ago.
It's an illusion, my friend.
It's an optical illusion.
Yeah.
No, it's lovely being back. It's lovely being back again.
Traveling.
Thank you for having me.
Yeah, so thank you for being here, and let's get on with the podcast.
Of course, thank you.
So we've been talking about this in the context of common feline chronic enteropathies. A lot of those would fall under the IBD umbrella.
Yes.
Right?
Yeah.
So let's just switch gears for a minute because the other common enteropathy in cats is lymphoma.
Yes, indeed.
So I'm assuming or maybe I shouldn't assume, is there any role for manipulating the microbiome in lymphoma treatment? Because we tend to focus on drug therapy.
Yeah, that's a fantastic question.
Right?
It's a really good question. At the moment, we are trying to modulate the microbiome in patients with chronic enteropathy associated with a lymphocytic plasmacytic infiltrate. And at least in the cat, there appears to be emerging and increasing evidence that this inflammatory milieu is often
It's like a continuum maybe, right?
Precisely.
Yeah.
It is a continuum. I think that's a good way of putting it. And I'm not aware of at least any results yet. Now, there are people looking at this. There are people looking at it, and I can't give too much detail at this juncture, but there may well be benefit to modulate the microbiome in an effort to see whether that can impact the severity of the lymphoma, or more importantly, or equally importantly, could I reduce the dose of my toxic drugs, prednisolone and or chlorambucil, when I juxtapose it with a transplant? And I think the answer is possibly yes.
It's a maybe.
For sure.
I think this is hugely intriguing, isn't it?
It is. It's very, very intriguing. But what I'll say, though, Susan, as well, is that, at least in our practice at UC Davis, I would say that the prevalence of small cell intestinal lymphoma, which is essentially the bread and butter of intestinal lymphoma in most of our feline patients, has surpassed that of inflammatory bowel disease. It really, really has. And again, is it a reflection of me seeing those patients in a biased environment where they've already been diagnosed or managed for their inflammatory bowel disease in the real world, and then they come to me because they now have recurrent diarrhea which did not respond to dietary manipulation or to prednisolone? It's possible, but we're also seeing some primary cases coming in that actually have small cell lymphoma from the get-go. And I think what I should really stress at this juncture too is that I don't want people to think that this is it's a black and white phenomenon, meaning it's either IBD or it's either lymphoma. Because if you took a cat to surgery or even to necropsy and you obtained multiple full thickness biopsies along the length of the intestinal tract, beginning at the proximal duodenum all the way down to the distal ileum, you could find an impressive number of cats that have histopathologic features of IBD, not far away from regions of bowel that actually have confirmation of lymphoma.
Yeah.
And we see that not uncommonly.
I
So
am happy that you're talking about surgery.
Ah,
Because
yeah, yeah.
now
Finally,
we can
Yoel has been
finally
waiting
have
for
a question
something
right
that brings
here.
He was
surgery in.
asleep. I
I
saw
know.
him.
I
Yeah,
was
he was
like-
drooling a little
I
bit
know,
because
it
he was
just
like,
out.
I was out of
And I
there.
just
I was
mentioned
like,
the word
mentioned
surgery.
surgery
and,
or
oh my God.
biopsy.
There he is.
He's
There he
awake.
is. There
He
is. So,
almost luxated his neck
Indeed.
as he
so
woke up.
there's
promise,
always
yeah.
a lot of discussion, and
Yes.
this is for surgeons once again.
Yeah, yeah,
And when you do an exploratory surgery, if you do it, and you have to take biopsies from
Yeah.
the GI tract.
Yes.
How many should we take,
How
and
many
where
and
should
where?
we take them?
Good question.
Wow, great question.
Yep.
Well, I'm going to answer that question, but I'm also hoping that we can have a very, very important conversation that's going to be focusing on full thickness versus partial thickness biopsy.
Yeah.
Is there a role or a place for endoscopically procured tissue samples from these animals? And is that inferior to full thickness biopsies that we might
Good.
obtain via
Let's go
surgery?
there.
Where should we go first?
Oh,
You tell me.
let's
'Cause
make
I'm gonna-
Yola happy, and we'll talk about.
Let's start
we'll
with
talk about
where,
surgical biopsy.
and then
Yeah.
why you prefer partial versus full.
Or might not.
Or might
Or
not.
not. Or
Because
not.
there's an obvious advantage of doing partial through endoscopy. It's minimal invasive. So,
Right.
Although we have now some minimal invasive surgical
Of course.
techniques that we can use.
Of course.
But that is the.
Yes.
But so here you
Let's
go.
start with if we're going to do full
So
thickness.
here's the key point. I mean, one has to recognize that chronic enteropathies in the cat are often patchy or segmental in their distribution from a histopathologic standpoint. And as a surgeon, when one goes in, if you can recognize the fact that this disease can be patchy or segmental, and that you as a surgeon may not be able to recognize on gross inspection what is abnormal versus what is normal, you now begin to appreciate the fact that if you were to procure a single full thickness biopsy from the duodenum and a single full thickness biopsy from the jejunum, that you are doing that patient and that owner a gross disservice, unequivocally. The conundrum, though, is that you are talking to surgeons and you're saying to them, and this is at the university, hey, so-and-so, I want you to collect 2 to 3 full thickness duodenal biopsies from different segments of duodenum. I want you to collect 2 to 3 jejunal biopsies from the jejunum, and I want you to collect 1 to 2 ileal biopsies, and while you're at it, please get me a chunk of mesenteric lymph node. Now, if I were to be on video right now, I could emulate some of the facial expressions that these surgeons provide.
Don't generalize.
No.
I love
Because
taking
Yola
GI
wasn't happy.
biopsies. I'm like,
Yola likes that
bring
answer.
them on.
Can you-
Bring them on.
Can we talk to Hills about you coming out and,
Yes.
and
Yola
just
loves that.
relieving?
Yes.
Look, and I'm not throwing our surgeons on the bus. They are an awesome team, and we're lucky to have them on board. But yes, there's obviously concerns about safety. There's concerns about
Yeah.
time. There's concerns about does it make a difference? Okay.
Yeah.
And I think that we have this. It's not a battle. It's a very healthy discussion. But certainly, as an internist, as a gastroenterologist, I feel strongly that I want to be able to procure at least 2 full thickness biopsies from the duodenum, 2 from the jejunum, 1 from the ileum, and I'd like to get some regional lymph node whenever possible as well.
Yep.
Now, cats, we haven't mentioned this yet, triditis,
Ooh.
while they're in there, and this
Yep.
may be one other important benefit of surgery,
Yeah.
is you've got access to the liver. So one could easily collect multiple excisional biopsies from the liver because we need to know whether that cat has cholangitis or lipidosis. If it has cholangitis, what form is it, etc. And we'd also want to look at that pancreas.
And
So,
biopsy it.
and we could definitely biopsy it as well, of course.
People are still afraid of biopsying Mr. Pancreas.
Oh, they are
But
indeed.
You can biopsy Mr. Pancreas.
You can biopsy
as
Mr.
long
Pancreas.
As you're respectful.
Be respectful. I love it. You know what? You must be telepathic.
Yes.
I swear, God. I was going to say, as long as you're respectful and you treat this organ.
She is amazing,
She's
but also a
amazing.
little scary.
No,
You know?
she's
Yeah.
lovely. Oh, no, she's lovely.
This is me in lectures.
Oh,
Be
no, she's
respectful
lovely.
of Mr. Pancreas.
Oh, no, I love that term.
Right, you can do
But
it.
I was going to say, so we, at least at UC Davis,
Why is the pancreas male, by the way?
Oh, because you have
Why
to
is
be
it not
very
Mrs.
careful.
Pancreas?
You have to handle them with care.
This could be interesting.
Okay, this is going to be. Let's.
We'll talk later.
I didn't ask that question.
I didn't even know that we had a gender for the pancreas.
I do.
Indeed. All right.
Yeah, okay.
I'll get into trouble if I say. Okay. Yeah. So, but our surgeons typically will go ahead and collect 2 full thickness from duodenum, jejunum, one from the ileum usually, and get us some lymph node.
Yeah.
Recognize too, then, this is important for veterinarians out there, that if you were to look at the segment of small bowel that is most commonly involved with small cell lymphoma,
It is.
it is the jejunum. Ka-ching. It is the jejunum. And that is important when one is beginning to plan the potential method of procuring tissue from the bowel. And it's really important to be able to access the jejunum endoscopically if you're relying upon that particular procedure.
Yeah. So just to go back to the original question.
Yes.
So you say at least 2 of the duodenum, then you can make as many biopsies in the jejunum because it's so big. So 2 probably is not enough, but 2 to 3 you say.
Yes.
Ileum, as a surgeon, I would be a little worried about because it's not that big. I mean,
Correct.
in a cat, it's probably a couple of centimeters.
Correct.
If you take 3 biopsies, it's like a
Absolutely
whole
right.
incisional.
No, totally. We typically rely upon 1 full thickness biopsy from the ileum, recognizing as well that we can certainly see some variability. One thing that I want to preface if I forget is that when these cats are being assessed for their chronic enteropathies, the assessment of cobalamin status cannot be overemphasized.
Yeah.
And we usually have the luxury of getting a B12 back before we perform biopsies of the gastrointestinal tract, whether it be full thickness or partial thickness. So we can run our B12s in-house.
Yeah.
And I guess what I'm simply saying is that if a cat is hypocobalaminemic, it is pivotal that one does not forget about the importance of collecting tissue samples from the ileum. And Mike Willard eloquently showed years ago in the Journal of Vet Internal Medicine that it's not uncommon for the ileum to be the segment of bowel that's involved with small cell lymphoma, and in the upper segments of bowel, you've got inflammatory bowel disease,
like
for
IBD.
example.
Yeah.
So, I mean, it's an important part of the bowel that we should not ignore.
I'm glad you mentioned
awesome.
that.
That's awesome. You haven't answered the partial versus full.
Yes. Yeah.
Oh, let me do it.
Yes.
Let's do it.
So, because in my practice we scope a lot of cats, but we
Yes.
also do a lot of X-laps.
Yeah.
So we do both, and this is an ongoing debate. And you certainly see people who say, "Oh, they all have to be full thickness," and you see other people who say, "Eh."
And we had this discussion about scoping cats. It is not that difficult.
Yeah, Yola and I recently had a discussion because we heard of a colleague who thinks cats are too difficult to scope. So too bad we don't have some video right now because Stan just had really. You had a very similar facial expression
I went
to me.
ophthalmic.
Now we need an opto lecture.
Yeah.
So, but I think that's unusual. So
Yeah.
lots of people like to scope cats. So talk a little bit about
Look,
that.
Here's my concern and my frustration. I'm going to be honest with you. There have been several peer-reviewed publications in the veterinary literature that have endorsed the benefits of full thickness biopsies obtained surgically, obviously, at the expense of partial thickness via endoscopy that I think have truly done a disservice to our profession.
Yeah.
Honestly.
They put a bias in
These
there.
are weak studies that have been fundamentally flawed, that do not portray the full picture of what we should be really talking about. And I'm concerned that veterinarians who read the literature are looking at this misinformation, which is of great concern to me, as I mentioned before.
And speakers talk about it too. It's not just in the literature.
Of course.
Yeah.
Here's the thing.
This episode is made possible by the generous sponsorship of the Take the Pledge Against Struvites in Pets Facebook page. Did you know there are 3 easy steps to treat bladder stones in cats with lower urinary tract signs? Step 1 is to take a radiograph, and if there is a stone present in the bladder, step 2 is to use the Minnesota Urolith app for iPhone and Android to determine the most likely type of stone. Step 3 is to treat the cat for at least 2 to 3 weeks with an appropriate diet and see if the stone gets smaller. If so, keep feeding that diet until the stone is completely gone on follow-up radiographs. If not, check compliance with the owner and look for alternative treatment options. Join veterinarians worldwide to take the pledge not to remove struvite stones by surgery anymore.
When you look at lymphoma, it is a malignancy that begins in the mucosa. And over time, depending on that malignancy, it can ultimately become transmural. When you look at the notion of collecting partial thickness biopsies collected via endoscopy, it should be stressed that one is collecting between 13 to 16 pinch biopsies of the duodenum, and for cats with reasonable skill levels of the operator and an appropriate length endoscope, you should be easily able to access the jejunum, and you should be able to get sufficient samples from that segment of bowel without any problem at all. That also being said, to access the ileum, one has to go transkolonically. And with a bit of practice, you can easily get into the ileum of the cat, and I usually will procure 10 or 12 pinch biopsies from the ileum. When you look at the collective surface area of the mucosa that I am getting from the duodenum, where I'm getting on average 10, 12 intestinal villi per partial thickness biopsy, and you collect those together with my duodenal biopsies, with my ileal biopsies, you cannot for a minute begin to tell me that you are going to get a greater or wider representation of bowel when you go in surgically. That is absolutely nonsense, okay? Where you're going to beat me from a surgical standpoint, if you want to play that game, is that you are going to get a full thickness biopsy. And if you talk to pathologists like Peter Moore, who's written a book on intestinal lymphoma in the cat and has done an incredible job and contribution with our knowledge of this disease, he would argue vociferously that partial thickness in the eyes of a competent pathologist with good quality biopsies, I need to stress that, getting biopsies perpendicular to the mucosa, not getting villus tips with poor technique is more than adequate and might even be superior in his experience. And again, I think that if you are a veterinarian who is not highly skilled or well practiced in performing endoscopy, and you aren't able to get through the pylorus, or you get through the pylorus and you're just in the proximal duodenum, and you're trying to compare that to a surgeon going in and getting the several sections that we spoke about, obviously that's not a fair comparison.
Right.
And in the paper that I'm referring to, at least one of them, some of the animals included, they could not get through the pylorus endoscopically.
So there you go.
So that's a bit of a concern. So to me, it's collective surface area. I want to know what's going on at the mucosal level, and I'm not as interested in knowing is it transmural or not.
So if I translate you,
Yeah.
what you probably would do is endoscopy as your first step. Take all those biopsies from, the ileum, from the duodenum, probably also from the jejunum. You can look in the stomach and that sort of thing.
Yep.
If you don't get your answer, then the next step could be that you do full thickness.
Let me take a step back. Not quite in that capacity or fashion. We are very spoiled, and I want to stress that this is not the same as the real world. I typically am able to have a top radiologist boarded with a resident at his or her side doing abdominal ultrasound within 2 to 3 hours of me evaluating that patient. I'm able to get blood work back within several hours of me submitting my CBC and chemistry panel and B12 folate to our lab in hospital. And I'm going to be the first to admit that that gives me a tremendous advantage and benefit, because I can look at this patient, not just from its history and physical exam, but its lab work and its imaging findings, and say, whoa, this animal should also get liver biopsies.
Yeah.
Okay?
Yeah.
This patient
Yeah.
has a weird lesion on its pancreas that I need to further explore or investigate. I'm not going to do endoscopy on that animal.
Yeah.
Hell no. It's going to go to
Of
surgery.
course.
Yeah.
Okay? And if we want to get colonic biopsies, I should just stress this as to be complete, we will usually use endoscopy to collect partial thickness from the colon and try and minimize the need for getting full thickness sections from the colon, unless there's a mass, of course, that warrants removal.
Yeah. So I think that makes sense, right? There's room to evaluate your patient and say some are probably better to go to surgery, which is essentially what we do. So the other thing that's popped into my head, because it's a common problem for me, and I'm sure it is for you. So we've talked about how IBD and lymphoma for some patients might be a continuum.
Yes.
So, and we will sometimes get histopath reports back where the pathologist is unsure.
Yep.
So next step, PAR testing, immunohistochemistry.
Yeah.
So let's talk a little bit about that.
Yeah, that's a good question.
Yeah.
And again, I think the question surrounding the H&E sections is going to be dependent on which pathologist is assessing or evaluating those tissues, samples, as you know. But certainly, immunohistochemistry, with the advent of us being able to stain these lymphocytes with a CD3 marker, for example, and assess if these are all of a T cell immunophenotype, is very readily done and does give you an additional layer of benefit. That being said, with the advent of molecular testing to do PAR or clonality, that does give you another layer of increasing sensitivity. But I want to stress that PAR testing should never be done in isolation. The PAR testing is a part of a complex puzzle that is being used to help further investigate the likelihood of an H&E section and immunohistochemical stain section being lymphoma, because we can certainly see PAR negative lymphomas, especially when you have an early emerging lymphoma in an inflammatory background.
Sure.
And can you explain to the audience what you mean with PAR testing?
Yeah, I mean, essentially, PAR testing that can be done now through different reference labs and through, our university and many other universities as well, is the testing, I should stress too, by the way, can be done on formalin-fixed sections.
Which is nice.
So that's beautiful.
Yeah.
So you've collected your tissue samples for H&E staining, whether they be full thickness or partial thickness. They're in a block. And you now want to go ahead and do additional testing. You can basically take sections from that block, send them to a reference lab or to the university where they can go ahead and process those accordingly. And essentially what they're trying to just do is determine whether the cells, the lymphocytes, are of a single clone, which would be more consistent with lymphoma, or are of multiple clones, which is more consistent with inflammation. And so they can look at this genotype, essentially, of these cells to make that determination. And as I said before, it's not a perfect test. I can say that at least at UC Davis, this is done in triplicate, and we have seen early emerging lymphomas that could be missed potentially because you've got this profound inflammatory background, and that if you were to wait 6 months or longer, it might be more obvious with both H&E stain sections or with clonality. So we don't routinely do clonality on all of our biopsies. We do not. And I will say this too, that's probably an important point to think about, is we've done some work at the university with a big reference lab, and colleagues of ours at Texas A&M have also done some beautiful work which has not been published, so I want to be careful how much of this I divulge. But what's a little bit concerning is that there's unequivocally a population of cats who either have no clinical background. So these are animals coming in for a routine elective dental procedure.
Yeah. Okay.
Beautiful animals.
Yep.
Any weight loss? Nope.
Yep.
Any vomiting? Heck no. Diarrhea? Beautiful stools. And the animals are being scoped while under anesthesia for their dental procedure, and are then having those tissue sections reviewed histologically, with immunohistochemistry, and with PARR or PAR. And there is a subset of cats that are clonal that may not be reflective of the H&E biopsies, and that is a question.
Wow.
There's several theories as to what that may portray, or may these be very early cases that if you were to follow them out longitudinally, they may develop
Because
lymphoma.
they're clinically normal.
They're
so who
clinically
knows?
normal.
Yep.
They're
So who
clinically
knows?
normal.
Yeah.
In the work that we've done so far, I'll simply say at UC Davis, it is exceptionally rare, almost unheard of, to have a feline patient with a chronic enteropathy having intestinal lymphoma at an age younger than 5 years.
Yeah, it's a middle-aged cat.
That's sort of a
Yeah.
general rule of thumb. So
Yeah.
if you were to
Yep.
see a cat that's 2.5 years of
Yeah.
age with chronic diarrhea,
Yeah.
might it have small cell lymphoma? Of course, it's on the differential list, but is it likely? Heck no. The cats that we look at, and those that have been done by a large reference lab in the area, have typically been 5 years of age or older when they were diagnosed. Yep.
So this is all really cool. I think we need to finalize the podcast. Normally we have podcasts of
no.
about 25 minutes.
We
and
haven't been going along.
I know.
And we're talking about diarrhea.
Keep
Are you
on
kidding me?
talking about. So we probably have to come back to talk about diarrhea.
Goodness me.
Just
At a pub or something like that, maybe.
I think so.
If you think about people in practice,
Yes.
so we have a lot of fans for instance, from Brazil.
I want to go to Brazil.
Well, hey,
He is an awesome speaker, so
no.
invite him.
we'll make it happen.
We'll make it
happen.
happen. But so I'm in practice, and I have a 1 or 2 person practice.
Yes.
What are the essential tests that you would tell them to do with a cat with a chronic enteropathy?
It's a great question, especially from a surgeon, I will say. That's a really, really good question.
I'm impressed.
No, that's
actually.
a wonderful question. It's a practical one. It's
yes.
relevant.
Go Bellamy.
Look, and I tell my students this every day. I mean, the art of the history and the physical examination
Oh,
cannot be ignored.
Oh, Stan, I
And
love you for saying that.
Oh, thank you.
You know, it's old school, but it won't change.
It will not change. And I like I say, I mean, I'm in the middle of teaching our GR block now to our junior, third-year vet students. They're awesome too. And yeah, I keep coming back to history, physical exam. And I tell them, and I will say this to veterinarians in practice, when you leave the examination room and you've done your due diligence with your history and your physical examination, and with experience, you can begin to formulate a list of most likely differentials because you've already created a problem list from that history and physical exam. And you should be able to create your top 3 or 4 causes for this particular animal's enteropathy, that blood testing and imaging of the abdomen is essentially going to be the icing on the cake to confirm your clinical suspicions. Where veterinarians get into trouble is when they haven't got a rational approach to these patients with their chronic bowel disease. And when you look at things piecemeal and they don't make sense, you then begin to throw mud against the wall to see what sticks, and that's when you get into trouble. So you have to have a rational approach whenever you're looking at these animals, and it becomes easier the more you do it and the more you practice it. But I'll simply say this. In a cat with chronic enteropathy, we typically are trying to ask ourselves, does this patient have primary bowel disease, or is this enteropathy and the clinical manifestations thereof extra GI? And again, your likelihood of leaning one way or another depends upon the signalement of that patient, for example. If I've got a 15-year-old cat with weight loss, polyphagia, intermittent vomiting, and diarrhea, I am making sure that that cat is not hyperthyroid. Certainly, we haven't discussed this at all, pancreatic insufficiency is a lot more common than what veterinarians have given that disease credit for in the cat. Oh, it's totally out there. And in fact, I was just in Thailand, as I mentioned, in Pattaya, with Jörg Steiner. Jörg Steiner from the GI lab, and he was phenomenal. But he was.
They have great data on.
No, they've got. That's the beauty of that lab. I mean, it literally is. It's a gold mine for amazing data that. Thousands and thousands and thousands of submissions every year where they can look at these TLIs and say, holy crap. And what he eloquently showed in his presentation was that the prevalence of EPI is definitely increased markedly over the last 15 years or so. It's huge. So the point I'm trying to make really quickly is this, is you've got your history and signalement that helps you determine is it primary GI or extra GI. Blood testing and imaging, typically with ultrasound of the abdomen, is also helping you to make that prioritization, that separation. Please do cobalamins in all of your feline patients with chronic enteropathy.
I love that.
Do not forget about the advent of fecal examinations. We tend to spend thousands of dollars on these workups looking at all of these wonderful diseases, and yet, depending on the animal and its environment, we don't include
Don't forget the
sample.
Don't forget the end.
Don't present, exactly. And so it's kind of embarrassing. I go through records of our database at UC Davis, and they've had CBC, Chem, UA, B12 folate, abdominal ultrasound, SPEC, FPL, TLI. Fecal done? No.
Then the answer is roundworms. That's very embarrassing.
So anyway, or empirically deworming as well is another approach. But getting back to your point is this. Chronic enteropathy database is critically important. A CBC, a chemistry panel. I would say that a urinalysis was one of the most underappreciated and underperformed diagnostic tests in the veterinary planet. And even if one's not going to do a full UA, urine-specific gravity in a cat presentation is pivotal, because especially when that BUN comes in at 47 and the creatinine's 2.1, you're saying, is it pre-renal, is it renal, what is it? That USG would have been pivotal in that example. B12 folate we spoke about, abdominal ultrasound, fecal flotation, centrifugation flotation as well. A Giardia ELISA test will markedly increase your sensitivity when performed in parallel with the fecal flotation. About 97% in our research published in cats when you look at an ELISA test done in combination with a centrifugation flotation. And remember, Giardia is a small bowel pathogen, not a large bowel pathogen. And then we, depending on the patient, segment, severity of clinical signs based upon a disease activity index, could try a dietary trial with or without B12 supplementation if warranted. And if the dietary trial, usually in our practice using an elimination diet containing a novel single protein source or a hydrolysate, and there are some variations too with fiber coming into play, if that doesn't do the job, then we want to get tissue samples from these patients as well. And we usually will rely upon endoscopy unless there are other reasons that we spoke about earlier on to get full thickness biopsies intraoperatively or via laparoscopy.
That's awesome.
Cool.
That's awesome. I think this was a great podcast. Thank you so much.
No, you're more than welcome.
For being with us, and we almost have to stop you talking.
Oh my God! But next time,
I think we've got multiple podcasts.
I think that next time, what we're going to do at a wonderful restaurant in Rio de Janeiro. I can see this happening right now in my crystal ball.
I like your
because we haven't discussed nutrition per se, and of equal importance, we didn't discuss the management of the cat with small cell lymphoma.
Indeed.
The different protocols, the controversies, the rescue drugs,
we have
and outcomes.
So many more podcasts coming.
I love it.
Absolutely. So thank you very much, Stan, for being here.
This is fantastic. What a great opportunity and an ingenious idea. Ingenious.
Thank you. And he didn't say the D word.
I know. I have one
so
disappointment. I have one disappointment because if people say the D word, then they have to buy us a glass of wine. And Stan, you're a disappointment. You never said the D word.
I was told not to say the word, and I did my best to heed your advice. It was very easy.
Well done.
Excellent.
Thank you, guys. I really had a lot of fun. Take care.
The opinions of this podcast are those by Dr. Susan Little and Dr. Yola Kerpenstein. Veterinary medicine is a complex profession, and often there are multiple diagnostic and therapeutic options for different disease processes. If you're a pet owner with questions, please go to your local veterinarian. If you're a veterinary professional, ask your questions on our Instagram page @PerPodcast. Dr. Susan Little is a feline medicine specialist with 2 cat-only hospitals in Ottawa, Canada. She is best known as an international speaker and as the author and editor of 2 textbooks, The Cat, Clinical Medicine and Management, and August, Consultations in Feline Internal Medicine. Along with 3 cats, she also admits to owning 2 dogs, and you can follow her on social media with the handle @CatVetSusan. Dr. Yola Kerpenstein is a diplomate of the American and European College of Veterinary Surgeons and a big cat fan. His specialties range from surgical oncology and reconstruction to minimally invasive surgery. He is the author of 2 textbooks on basic and reconstructive surgery. Did you know he was allergic to cats? Yola works currently at Hill's Pet Nutrition. You can follow him on social media with the handle @GVETSX.